Welcome to the Onvida Health Base Hospital EMS Treatment Guidelines video tutorial series. This is Dr. Franco Castromarin, and you're watching Part 4, Resuscitation. This video is intended for any EMS provider who's operating within Yuma County with Onvida Health, formerly known as Yuma Regional Medical Center, as your base hospital and administrative medical direction. Please confirm with your chain of command if you are not sure. The primary objective for this Part 4 video is to go over in detail every page of the treatment guidelines in the resuscitation section. The setup is simple. When I'm comparing a new guideline to an older version from the YRMC protocols on the same or similar topic, the new version will always appear on the right of the screen and the old version will be on the left. They will be labeled in the top left corner of every page, new versus old. Having the old material available for comparison will help you build familiarity and comfort with this new content. Along the way, I'll point out important details on each guideline and share some effective teaching pearls. Remember, you will always have access to this training content, and you can come back to review it at any time at your own pace as often as you'd like. I encourage you to have your mobile device out and use it to follow along as you watch these videos. One of the advantages to this rollout is that we are using the same mobile app vendor called Acid Remap to host our guideline document, so much of the app navigation should be familiar to you already. As you may know from using the Acid Remap mobile app, there's a way to make your own notes. Feel free to use this function frequently as you pick up useful teaching pearls from these training videos. This is the first guideline in the resuscitation section. New this year, we've developed this guideline to help you manage a crashing medical patient. A crashing patient is one who is rapidly deteriorating into cardiac arrest within the next few seconds or minutes and who demands swift, decisive, and coordinated action. This action needs to be so well understood and rehearsed that it essentially becomes reflexive. Several high-performing EMS agencies across the United States have developed specific guidelines tailored for these scenarios. Our Medical Direction Consortium reviewed some of these and used them as inspiration to create this new guideline to improve outcomes, ensure consistency, and enhance your confidence in managing these critical events. There are several important benefits to having a specific guideline for a crashing patient. First off, it helps to improve patient outcomes by helping you recognize signs of deterioration faster, allowing for timely interventions that can prevent cardiac arrest. It helps streamline critical actions such as airway management, vascular access, and medication administration. Also, as we've mentioned in prior videos, it helps to reduce variability and eliminate guesswork, regardless of who might be providing care or whatever the circumstances might be. Next, this guideline helps to enhance team coordination and communication through assignment of specific roles and responsibilities, creating a shared mental model for all crew members to understand what the priorities are, and it helps to standardize communication during handoff to the hospital. Finally, we're looking to increase confidence and reduce stress by providing a roadmap that focuses on execution of tasks and hopefully providing clarity under pressure. This guideline transforms high-pressure emergencies into a more predictable, well-managed situation. So let's break it down. First off, this is only intended for medical conditions, not patients who are crashing because of trauma. On the other hand, it is designed for all ages. You're going to recognize a crashing patient by features such as inability to follow commands, airway and breathing problems, and obvious circulatory collapse. Right up top, we set the tone by prompting you to prepare to manage the situation on scene rather than moving the patient too early. If the scene is safe and you have adequate access to the patient as well as your equipment, you should perform your life-saving interventions first before trying to move locations. Next, we emphasize just how important it is to trend your vital signs early and often. The trends guide most of your actions. Make sure the monitor is applied, including continuous end-tidal CO2. At this step, go ahead and apply the defibrillator pads as well while you're exposing the patient. The idea is to have all your tools in place before you're going to need them. Make sure to assign someone to have fingers on the pulse at all times. Next, we pivot to airway and breathing. The goal is to get saturations to 94% or better, and interventions need to be applied as soon as possible. Now keep in mind, this 94% oxygen target is an ideal goal. You can see we have a specific target for blood pressure as well. The idea is to try to hit those targets, but also realize that achieving them may not be possible. You got to do what you can and then move on with your process. So back to airway and breathing, look for clues in your assessment, such as increased effort of breathing, inability to speak full sentences, or even worse, the patient might be unable to speak at all, and they may be unable to sit up or actually be totally limp. They may be turning gray or blue. Obviously, you're going to be looking at oxygen saturations and looking for abnormal end-tidal CO2 readings. Whatever the case, address airway support and interventions in the usual way, but as quick as you can, escalating from the least invasive to most invasive approach as we discussed before. That being said, in a case like this, your most likely starting point is going to be at least a non-rebreather mask at 15 liters per minute or more, or moving quickly and directly to BVM ventilation. Don't forget to use the 2 rescuer BVM setup with 2 NPAs and an OPA. Paramedics can consider CPAP if the patient can follow commands. Otherwise, this line reminds you that we expect the first airway device intervention to be a supraglottic airway. Endotracheal intubation is to be reserved for scenarios where a supraglottic is either contraindicated, failing, or otherwise not feasible. As always, front of neck surgical access is considered a last resort. If you have the manpower available, another paramedic should be simultaneously focusing on the circulation assessment while airway and breathing is being addressed. The idea here is to get the systolic blood pressure above 90 for adults and age-appropriate blood pressure for pediatric patients, or a mean arterial pressure above 65. This is the threshold that is felt to be high enough to perfuse the vital organs, including the brain, the heart, and the kidneys. Make sure you prepare push-dose epinephrine as early as possible so you have it ready. From here, we break the situation down into one of 3 categories: bradycardic peri-arrest, general shock not due to a heart rate problem, and unstable tachycardia. Let's take a look at bradycardic peri-arrest first. You can refer to the bradycardia review I included in part 3 of this video training series for a more detailed review. As we discussed in that time, assuming the patient still has a palpable pulse, detectable blood pressure, or other signs of life, make sure to manage with a dual approach of both transcutaneous pacing along with push-dose epinephrine, just like we reviewed earlier. With a patient this sick, you don't want to delay things by trying only one step followed by the other. Hit them with both as close to the same time as possible. If they are pulseless, obviously you need to pivot immediately to cardiac arrest management, and here is the hyperlink for that. The next category is patients with general shock not due to a heart rate problem. Your interventions here will focus on push-dose epinephrine as your first line and IV fluid support as your backup. The last category is tachycardic patients. We keep it very simple here: shock early and shock often, then transport safely and rapidly. Hopefully it's obvious, but you're not going to rely on push-dose epinephrine for patients with unstable tachycardia, because this will only potentially make the tachycardia worse or push the patient into a lethal arrhythmia. For your easy reference, we include all of the relevant push-dose epinephrine dosing and mixing parameters here at the bottom of the page. In my own experience, I'll just share with you that early administration of push-dose epinephrine has saved me many, many times in this scenario. Again, if you have the numbers, a paramedic needs to start mixing this as soon as you recognize that your patient is crashing or you see that the situation creates substantial risk for quick decompensation. So that covers the crashing medical patient guideline, new for 2025. It is true that much of this information can be found on other pages, but this one reframes the most critical steps on a single page for you. Hopefully, this will ensure a consistent, evidence-based approach that fosters teamwork and builds confidence. Please consider scenario-based training and tabletopping this with your crew during the year. Okay, here is the big one: cardiac arrest. Now, as you can see from the title, we combine all rhythm classes into one streamlined approach. I promise most of you will agree that this new approach will be much easier to remember and follow. Inclusion criteria are pretty straightforward. You're going to use this page for any patient of any age who is in medical cardiac arrest. We no longer split up between adult versus pediatric. If the patient has return of spontaneous circulation, you can use this hyperlink to get to the correct management guideline. Having said that, as you already know, neonatal resuscitation for the newly born neonate is handled differently, and therefore we keep this hyperlink to the correct guideline for neonatal resuscitation. Obviously, anyone who has a valid DNR should not be resuscitated, so they're also excluded from this page. Now, the information on this guideline can also be used to guide cardiac arrest care for trauma, but you can see that we have additional trauma-specific information on these other two pages hyperlinked here. On the left-hand side of the screen, you can see that the old protocols broke up adult cardiac arrest care across 4 different pages. For the most part, the information on the old asystole and old PEA protocols was actually just about the same. Let's start this conversation by mentioning the things that we have completely removed on the new version. As I mentioned earlier in the video, all endotracheal drug administration is completely gone now that we have intraosseous vascular access. So endotracheal epinephrine is removed. The next drug to be removed is lidocaine as an antiarrhythmic. We keep amiodarone, and the dose is the same as prior. This keeps things simple. There's no need to have 2 options that perform equally for the same indication during cardiac arrest management. The best outcomes for cardiac arrest rely on our ability to keep things as simple as possible. It's already bad enough that antiarrhythmics like amiodarone don't seem to improve long-term survival and good neurologic outcomes. Next, we de-emphasize these lists of the 6 H's and 5 T's differential diagnoses for cardiac arrest. The reality is that there's only a few of these that can even be addressed by EMS, and so dedicating time and focus to the others doesn't really help that much. You can see the section for considering other reversible causes here, along with their treatment options. We keep 1 toxin, that's opioids, for which you carry the antidote, of course, naloxone. We keep hyperkalemia, tension pneumothorax, and hypothermia. No longer should you consider routine administration of calcium and bicarbonate. These also have been shown not to improve survival after cardiac arrest. Same thing with this mention of 500 milliliter fluid challenges for PEA. That's pretty much useless, and it's gone. Okay, let's now turn our attention to the EMT section. Across this entire page, the key actions are in a specific order, and they appear in black bold typeface. First is starting compressions. Second is applying the defibrillator pads. Third is airway ventilation. Down here in the paramedic section, you can see vascular access as well as the continued cycle of compressions with rhythm analysis. Focusing on the EMT side of things, you're going to enter this encounter using the same approach regardless of whether you suspect a cardiac cause or a respiratory cause to the arrest. Remember on your old version you had a protocol dedicated to cardiocerebral resuscitation, or CCR. This was also referred to as minimally interrupted compression-only CPR. This was the version you would use anytime you thought the cause of the arrest was a sudden, lethal arrhythmia in a previously normal patient whose blood was fully oxygenated prior to the collapse. In other words, a purely cardiac cause. Therefore, the focus was on delivering high-quality chest compressions while you applied passive oxygenation for the first cycle of compressions. Now, let me just point out for a second that in your old version, it was incorrectly instructing you to intubate as soon as possible during the immediate supportive care step after the first round of 200 compressions. This is actually not correct. In compression-only CCR, you're not supposed to manually ventilate until you've completed 4 cycles of compressions and rhythm checks. My point is that in the old version, you needed to have figured out from the beginning of the encounter if you're going to follow CCR or standard ACLS, because you had a different protocol for each of these on different pages. In this new version, everyone in medical cardiac arrest will be approached the same as far as getting someone on the chest as soon as possible to start the first 2 minutes of compressions. That gives the rest of the team some time to set up equipment before you need to make any real decisions. You will see we include some bonus information here to remind you about what matters most in terms of compression quality. The target rate of compressions per minute, ensuring adequate chest recoil, and swapping compressors every time you perform a rhythm check. After 2 minutes, the person performing chest compressions gets fatigued to the point that only about 60% of their compressions are of sufficient depth and recoil. So make sure you are swapping them out accordingly. Next, while the compressor is doing their thing for the first 2 minutes, you can apply the defibrillator pads as soon as possible while avoiding interruptions of compressions. Below that action step, we prompt you to immediately perform a rhythm analysis no matter how many compressions have been administered. If the AED indicates a shockable rhythm or you identify a shockable rhythm on the monitor, defibrillate immediately. This next bullet defines the rhythm checks as occurring every 2 minutes, in sync with swapping out the person who is doing the compressions. Please note this caution statement. This is a very important detail that was not mentioned in the old version. Every time you administer a shock, you need to immediately resume chest compressions without pausing for a pulse check. Next is the airway and ventilation step. Now here is where we have to decide what category this patient should be in, because this will determine whether you should continue with passive oxygenation or start manual ventilations with a bag valve mask. The next bit of good news here is that the factors you use to decide this are much more clear. Here they are shown in bold red. Either the patient is a witness cardiac arrest aged 8 or more with a presumed cardiac cause, or they are not. It's that easy. Everyone else, including any unwitnessed arrest regardless of age, any respiratory cause like drowning, overdose, and anyone younger than 8 will receive immediate manual ventilation. These factors are unchanged from your old guidelines, but they are reframed so you can manage both categories of patients from one single guideline. Now, let's take a closer look at how we are going to deliver oxygen. The patients in the first category will receive passive oxygenation, and this can be done either with application of a non-rebreather mask set at the highest flow rate along with placement of an OPA, or better yet, drop a supraglottic airway. As you know, the adult-sized eye gels numbered 3, 4, and 5 all have a passive oxygen port built in that you can easily plug into. As I mentioned before, these patients are not to be intubated with an endotracheal tube during these first 4 rounds of compressions and rhythm checks. This last bullet within this category explains that if you have no response after 4 cycles of compressions, in other words, 8 minutes of resuscitation, then you will transition to manual ventilation with either a BVM setup, or better yet, simply convert your iGel from the passive oxygen mode to the normal mode by connecting the BVM and ventilating in the standard fashion. For everybody else, there is no passive oxygenation phase. Just start immediate manual ventilation with either a bag valve mask setup or supraglottic airway. Very important though, we are no longer adhering to any type of 30:2 ventilation ratios. Unnecessary complexity. All you have to know is that the ventilation rate is 10 breaths per minute or 1 breath every 6 seconds, and that ventilation can be administered asynchronously relative to chest compressions. And by the way, this is true of all ages. So why do I keep pushing the supraglottic device rather than endotracheal intubation? Because studies have shown that outcomes are generally the same between both devices. However, supraglottic airways can be placed faster with a higher degree of operator confidence and fewer interruptions to chest compressions. So relatively speaking, that makes the supraglottic airway a preferred approach compared to endotracheal intubation. So what is a paramedic doing during all of this? Well, they need to be establishing intravenous access. As you can see with this emphasis, this needs to be done as soon as possible while the rest of the crew is focused on chest compressions and defibrillator pad placement. Much like the thought process with supraglottic airways, we recommend using an intraosseous approach because it can be done quickly and generally results in less interruptions of chest compressions. Once that is placed and functioning, be sure to administer the first dose of epinephrine as soon as possible. This concept has not changed from the old version. Drug dosages are included right here. Now, I will point out that in order to keep things flowing smoothly around the 2-minute compression cycles, instead of using a clunky time interval of epinephrine repeated every 3 to 5 minutes, let's just stick with an even 4 minutes so that drug administration lines up with the rhythm checks. Another issue, which is new and very important, is that we only give a total of 3 doses of epinephrine. That's it for the entire code. In fact, let's say, for example, you are able to get return of spontaneous circulation after the 2nd dose of epinephrine, but then you lose pulses later and have to resume compressions. You have the opportunity to give the 3rd dose of epinephrine, but no more than 3 total doses for the duration of the entire code. I'm going to come back to that in just a minute. Below the epinephrine dosing, we instruct you to maintain a smooth cadence of consistent cycles of high-quality chest compressions with rhythm analysis and defibrillation every 2 minutes and medications repeated at every other rhythm check pause. We include the hyperlinks that list the correct energy settings for all the different monitors as we have done on prior pages. Next, we include our standard amiodarone for ventricular fibrillation and ventricular tachycardia, as well as magnesium for polymorphic ventricular tachycardia. The dosing is the same, but in the new version we express the dosing in a weight-based format so it can apply to patients of all ages. We close the guideline with this new, more sensible, shorter list of other reversible causes worth considering, and then a final statement directing you to consider either termination or transport to the emergency department. Let's put up the 2 outgoing pediatric cardiac arrest protocols now. First, on the VTAC and VFib page, all of these primary actions of compressions, oxygen administration, rhythm checks, and vascular access are all the same. Again, we remove lidocaine along with endotracheal drug administration and de-emphasize the list of H's and T's. And the reason we don't state the pediatric energy doses is because, like I said before, we include the hyperlinks to each brand of defibrillator, and you can find those energy doses according to each manufacturer on that other page. As far as the asystole PEA page, again, we removed endotracheal drug administration and don't bother with fluid challenges. Okay, so why only 3 doses of epinephrine? Well, a major study was published back in 2019 that looked at over 40,000 out-of-hospital cardiac arrest cases in the United Kingdom. And what they found was pretty striking. Survival to hospital discharge was highest in the patients who received just 1 to 3 doses of epinephrine. Once you end up going beyond 3 doses, survival drops essentially to 0, and the chances of a meaningful neurologic recovery go down as well. Those findings lined up with other major studies like the Paramedic 2 trial, which showed that while epinephrine does help restart the heart and get higher rates of ROSC and arrival to the emergency department, it doesn't necessarily improve long-term survival with good brain function. In fact, more doses can lead to worse outcomes. Patients experienced much more heart dysfunction and much worse brain perfusion after return of spontaneous circulation. So what does this mean for us in EMS? Well, the big takeaway is that giving more and more epinephrine doesn't result in better outcomes, the outcomes that we're looking for, going home from the hospital neurologically intact. In fact, stopping at 3 doses gives us a better chance to pause, reassess, and also create space for what really makes a difference: high-quality chest compressions, early defibrillation, and addressing reversible causes. And at that point, after your 3 doses are administered, it's also reasonable to start thinking about whether you're going to continue this resuscitation or whether it's time to consider termination or transport. Now, at first, the limitation on medications seems a bit uncomfortable for a lot of us. It just feels like we need to do more for these patients. Now, just know that this 3-dose cap for epinephrine has been the standard of care in both Maricopa and Pima counties going back maybe 3 or 4 years now. And it's the same standard used by high-performance EMS agencies pretty much across the world. You may notice that the emergency department will deviate from this practice, and the primary reason for that is because patients who are in cardiac arrest at the hospital have priorities and opportunities that are very different from those in the field. The bottom line is that this cap of 3 doses for all ages represents the best evidence and best practice based on current knowledge. This is the approach that I would expect for myself as well as members of my family. Okay, that's a lot of information. Let's tie it all together. To summarize, this updated cardiac arrest guideline represents a major improvement over the old version that was fragmented across 6 different pages. Everything is streamlined onto a single, easy-to-navigate page that aligns with the latest AHA recommendations and best practices from other leading sources. We've eliminated some outdated and ineffective interventions such as endotracheal drug delivery, lidocaine, routine calcium and bicarbonate use, as well as unnecessary fluid challenges. Instead, we bring the focus to what actually improves outcomes: high-quality compressions, timely defibrillation, early epinephrine, and minimizing interruptions. The new approach simplifies care by unifying adult and pediatric medical cardiac arrest all into one process. Key actions are clearly prioritized for both EMTs and paramedics, and airway management is now more intuitive with clear criteria for when to apply either passive oxygenation or early manual ventilation. We've also emphasized early intraosseous venous access and highlighted supraglottic airways as the preferred advanced airway, improving speed and reducing interruptions. Antiarrhythmic use is now de-emphasized just a bit, and reversible causes are pared down to only those that matter in the EMS setting. Overall, this updated guideline reduces complexity, eliminates low-yield interventions, and brings clarity and consistency to how we manage cardiac arrest in the field. Most importantly, it puts the focus where it belongs, on the actions that actually improve survival as well as best neurologic outcomes. This next page, titled Pre-Hospital CPR Timeline, is a graphic representation of everything we've just discussed on the cardiac arrest guideline. Across the top, you see a timeline, and we arrange BLS versus ALS action steps using the same color indicators as on the guideline pages. You can see these green items represent each 2-minute cycle of 200 compressions, and each of these cycles is going to be separated by a rhythm check and a shock if indicated. We include a couple of important reminders to swap compressors during every rhythm check pause, as well as a very important detail to make sure that each pause lasts no more than 10 seconds, as in ever, as in throughout the entire code if you can help it. These 2 boxes straddle both the ALS and BLS scope of practice because they can be performed by either team member. However, for invasive airway procedures, just remember to keep yourself within your scope of practice. These 4 boxes summarize all the critical actions for an ALS providers arranged by time. This is just included for your review and education. All right, so you did an amazing job applying your new evidence-based approach to CPR, and now your patient has achieved return of spontaneous circulation, or ROSC. What the heck are you supposed to do now? Well, the answers you seek are once again combined into a new 1-page format that is adjusted for all ages. Just like with cardiac arrest, the process has become more straightforward. So right up on top, I include a caution statement to help set the tone. It points out the fact that up to 40% of patients who achieve ROSC will experience rearrest prior to hospital arrival. The point is, have everything ready ahead of time and prepare for the worst. Remember that emergency medicine mindset we talked about earlier. Part of that preparation is to avoid moving the patient too early. Just like in our crashing patient guideline, you want to make sure that you have maximized all of your treatments, getting as close as possible to those optimal vital sign targets. Just like we talked about in the cardiac arrest guideline, the primary actions are listed in bold. These include supporting the airway, assessing and managing glucose, maintaining optimal hemodynamic stability while always being prepared for potential rearrest, and then critical actions for rearrest. The airway and ventilation parameters get split up by certification level here and here. All the basic information is up here in the BLS section, and the specifics on end-tidal CO2 are located here in the paramedic section. The typical oxygen saturation of better than 94% and end-tidal CO2 between 35 and 45 targets are unchanged from the old version. The next critical action for BLS providers is to identify and address any glucose problems. Appropriate hyperlinks are included, as you can see. The next section is about destination selection, starting with another clock icon statement. Cardiac arrest is obviously a time-sensitive situation, so we ask that you provide a detailed pre-hospital alert as soon as the resources are available. Ideally, all patients should be transported to main campus, but we include some scenarios here where you might consider going to the closest facility instead, so have a look at those. In this top area of the paramedics section, we remind you to maintain continuous cardiac monitoring, and we ask that you perform a focused reassessment of all vital signs every 3 minutes or any time you identify clinical deterioration. We have another clock icon statement here, reminding you to acquire and transmit a 12-lead ECG as soon as possible, and please make sure to notify the receiving facility if you identify a STEMI. The next critical action for paramedics is to address any hemodynamic stability issues. Again, we emphasize the importance of anticipating rearrest. Someone should have a finger on the pulse at all times. Have your push-dose epinephrine prepared and ready as soon as possible for every one of these situations. It's very important because this is the primary tool that you have to keep a patient from falling into the bradycardia and hypotension death spiral. As we discussed previously, dopamine has been removed altogether from the entire document, and we won't be using epinephrine as an infusion. Just keep repeating the push dose as you need. As you can see here, we include the hyperlink for the crashing medical patient since there's a lot of overlap between these two guidelines. We have a hard stop here to discontinue IV fluids if you are identifying any signs of fluid overload. We have a couple of comments on getting ahead of bradycardia. Below that, we have a couple of comments on how to manage rearrest. Obviously, you need to resume chest compressions, and we have a hyperlink to get you back to the cardiac arrest page if needed. As we just discussed on the prior guideline, here's a caution statement reiterating the fact that you are not to give any more than 3 total doses of epinephrine throughout the entire patient encounter. The count does not restart each time the patient achieves ROSC and rearrests. Finally, we close this guideline by informing you that we no longer use therapeutic hypothermia. It's sufficient just to make sure that the patient doesn't have dangerously elevated body temperature. The only time you should be rewarming a medical cardiac arrest patient is if they have true environmental hypothermia. Now, the old protocols mentioned midazolam for post-intubation sedation. You can always tap on the airway management hyperlink that we placed up in this EMT section, and you can find all the post-intubation medication orders at the bottom of that page if you need them. One specific item that has been removed from this new version is any mention of antiarrhythmic infusions. We won't be using those anymore. Stick with the amiodarone bolus dosing we discussed on the cardiac arrest page. Next up is obvious or apparent death. We have good news on this page. The old version was new somewhere around last year and based on the Central Arizona Regional EMS guidelines, same as this new version. So all this language here is nearly identical. The only new elements are this caution statement at the very top of the page advising you not to disturb anything if you're operating in a crime scene, as well as the addition of several helpful hyperlinks here in the exclusion criteria section in case you need to jump to a different guideline. Next is a guideline summarizing pre-hospital medical care directives, as well as some newer directive documents that you might encounter along the way. By now, almost everyone is familiar with or has encountered the orange form, which in the state of Arizona is the pre-hospital medical care directive, which we refer to most commonly as a DNR or do not resuscitate order. This form is a signed declaration that says when CPR and or intubation are to be withheld if a patient goes into cardiac arrest. All that description can be found up here on the top of the new guideline. We keep most of the other elements from the old version, such as the form having to be intact and having to include valid signatures, sometimes a photograph of the patient, etc. We keep language about proceeding with standard care if the patient still has signs of life. We did remove this 2-minute time limit in order to find the DNR form. Instead, the more appropriate course of action is to go ahead and start resuscitative efforts, which you can always stop later if the DNR form is eventually found. If you have the resources available on scene, someone from the crew can continue to look for the form while the rest of the crew is working on the patient. Now, as you can see, though, we've added descriptions of some of the other directives you might encounter. These include the POLST or MOLST forms, which stand for Provider Orders for Life-Sustaining Treatment or Medical Orders for Life-Sustaining Treatment, and other general advanced directives. These documents get a bit more specific and descriptive in terms of what treatment the patient desires. Just like the DNR form, these are also medical orders signed by a licensed clinician. The details of these forms can vary pretty widely from one patient to another. The bottom line is that you're encouraged to contact online medical direction if you encounter one of these alternate forms while you are initiating treatment, including standard CPR and airway management. The online physician can review these orders with you in real time and recommend the most appropriate course of action. This final guideline in this section is the non-traumatic termination of resuscitation page. Just like the obvious death guideline, this old version was recently updated from the same source material. Almost everything is copied directly to this new version. The only change was a simplification to these alternate termination criteria. We just removed this item of greater than 30-minute downtime with more than 60 seconds of pulselessness and a non-shockable rhythm. It doesn't make medical sense to keep it when we have these other criteria already listed. This concludes part 4 of the Onvida Health EMS Guidelines video tutorial series. Thank you for watching.